My name is Amwa Yabuakrain,
And you originate from where in Africa?
Ghana.
So, are you an MD?
Yes.
Where did you study?
Medical school was at the University of Connecticut School of Medicine.
Where did you do your residency?
I am still in residency training at Rush University Medical Center in Chicago, Illinois.
Can you tell me in a nutshell the poster you're presenting?
Yes, so it has been well documented that non-dysplastic large sessile serrated polyps are associated with synchronous advanced lesions. So our research question was for large non-serrated polyps, are they associated with advanced neoplasia in synchronous small polyps? So we had two groups of patients all undergoing screening colonoscopy first time. One group had a large adenoma associated with their small adenoma. And then the other group had small adenomas without any associated large adenoma. Then we went looking for the rates of advanced features in the small adenomas that were found. So small adenomas without any large adenoma, small adenoma with a large adenoma, and looking for the rates of advanced neoplasia in the small polyps. What we found was that the rate of advanced features in the small polyps that were associated with large adenomas, which by definition are advanced, was not that different. So whether the presence of a large adenoma did not affect the rate of advanced features in the small adenoma. And so what are the implications of this? There has been a group of people proposing that small adenomas, which are less than a centimeter in size, have low risk of progressing to cancer, i.e., there is a low rate of advanced features in these small polyps, less than a centimeter. So there's a proponent for not sending these polyps after resection to pathology. So this is the resect and discard strategy, where if you find a polyp that's less than a centimeter, you just cut it out and throw it away. And the caveat to that is that you use narrowband imaging so that endoscopically you can tell just by examining the polyp whether it has certain features that will make it high risk or not. And for the most part, the proponents are to throw it away. And what this study adds to that is that if by imaging you think the small polyp is low risk, the presence of a large adenoma on your examination next to the small polyp should not change that. It's still low risk, even with in the presence of a large adenoma.
So, in about 30 seconds, can you discuss your results finding?
Yes. So our finding is that the rates of advanced histology in small polyps are the same whether the polyp is found with a large adenoma or without a large adenoma.
And who was your supervisor?
My supervisor was Dr. Joshua Melson.
And what position does Dr. Joshua hold?
So he is one of the associate directors of the Comprehensive Colorectal Cancer Clinic at Rush University Medical Center. He's a gastroenterologist. He's assistant professor, last time I checked.
How many cases have you seen in the clinic that have corroborated your studies?
I have one patient in my continuity clinic who's had a colectomy for colorectal cancer, and I come across a lot of patients in my study on the wards, and colorectal cancer does affect their lives a lot, especially after cancer resection. There are a lot of problems with post with complications after colectomy and follow up, and so it does have a lot of burden